Bismillah ar-Rahman ar-Rahim. Dear Chairman, dear audiences, it's my pleasure to be among this elegant group today. And in the coming few minutes, I'll be talking about future and emerging therapies in IBD and how will it help. And since you know that future moves fast, I'll be as fast as possible. You know that advances has occurred in every particular area of therapy, of microbiome, of stem cell, surgical concepts, artificial intelligence, and in the omics. So all of this future development should add together, expand the armamentarium, ending up in personalization of medicine. So our target is to stratify our patients and treat accordingly. This emerging treatment of inflammatory bowel disease has emerged from the well understanding of the pathogenic mechanisms, which starts by microbiome dysregulation, increase cell membrane permeability, including macrophages, certain cells are monocytes, and others, in initiating an inflammatory reaction, which ends up by loss of the immune tolerance to our commensal bacteria. So you shouldn't worry if you find this big list of drugs, all of them you know, but there are new groups coming in, such as the sphingosine phosphate modulators and the phosphodiesterase inhibitor and the toll-like receptor 9 agonists. And very soon, you will find new groups and new medicines in the market, including the ozanimod and etrasimod and many, many others. So you are expecting a lot of medications coming to the market in the coming few years. This has resulted, as you have just heard from Professor Osama, in novel trends in the biological management of treatment. And you have heard about the sequential and the combined approaches, which is really starting to be more or less the approaches which we will work upon in the coming years. And this was presented by Professor Osama. You can start by infliximab or adalimumab. If you get a primary failure, you shift to a second line. If you get a secondary failure, measure the drugs and manage accordingly, with the advantage you have in treating ulcerative colitis of having another third drug already approved, which is tofacitinib. So you can see how things look more easy, more simple, and better approaches. And you can use this flexible way, dynamic approach between sequential and combination while you are applying your treat to target and personalized medicine. Remember that you have an already wide armamentarium of drugs which are really in the pipe, and many of them we have. So really, we are approaching a more dynamic approach. And this will be illustrated by this algorithm, which was also presented by Professor Osama. It looks complicated, but it's very simple. Just start the way you want. And whenever you fail, if you get a primary failure, you shift out of the class. If you get a primary response, optimize your treatment. And if monotherapy, add another therapy. But if you get a remission, look at the options you have. Continue. Give the patients an opportunity to remove one of the drugs, add another. Or you can give him an opportunity, if it's a very mild disease, to observe and see what is going on. If he relapses, many other options after measuring the drug level as well as the antibodies. Other advances have occurred in the microbiome, and without going into details, even in the pediatric population, the microbiome signature have been seen related to IBD, even in pediatric population. So this is well approved. But recently, they are starting to use the fungal and bacterial signatures to diagnose or predict the response to biological therapies. So this will be also something which will help our patients so much. But when we come to fecal transplantation, and as we heard this morning from Professor Afifi, fecal transplantation, if you compare it in patients with ulcerative colitis with drug elimination, you find the results of drug elimination much, much better than fecal transplantation. So don't worry, what we have seen in Clostridium difficile treatment was marvelous. We did not see this in cases of inflammatory bowel disease, whether Crohn's or ulcerative colitis. The maximum remission rate was around 40–45% whether in ulcerative colitis or in Crohn's disease. But don't lose hope. We know quite well that we are going towards precision medicine. You can stratify your donor and characterize your donors. Deep learning of machines will give you this opportunity to choose the proper donor to your patient. Blood banking will also be characterized. So there will be no more random fecal transplantation, and the collection of samples will be in a proper time when the patient is in a complete remission. Now there are new targets. You know that the armamentarium is expanding, a lot of drugs, a lot of medicines at the pipe. But look here also, you can find bacteria working also in the studies to reach a proper approach in reaching a percent of remission and the rate of remission, which is really comparable to medicines. This is a bacteria which works against vermicutis, and it has been showing marvelous results in approaching remission, very similar to many drugs. When we come to diet, a lot of advances is occurring in diet, and all of you know that dietary patterns are so much related to either protection of the mucosa or inflammation of the mucosa. Whatever people eat leaves a signature on their gut. Even this will result in really a resistant mucosa or in a mucosa which is very friable and liable to infection and inflammation. They studied a lot of things about diet, and they found at the end that not all emulsifiers, not all fibers are the same. Gums and carrageenans have a negative effect on the microbiome, while soy lecithin, which is used as an emulsifier, is only toxic in a very high dose. Inulin seems to be pro-inflammatory, but pectin has proved to be anti-inflammatory. So not all diet, not all emulsifiers, not all fibers are the same. And for this strong belief in the role of diet, the International Organization for Study of Inflammatory Bowel has approved this diet recommendations for both ulcerative colitis and Crohn's disease, showing what is very helpful to them and what could be harmful. So this is very important to be known. In spite of the fact that the ESPEN recommendations not to use diet elimination in other patients with Crohn's disease, you have seen in the last ECHO very nice studies showing the effect of drug elimination. The study by Levine have shown that eliminating Western types of diet in patients who have Crohn's disease associated with partial enteral nutrition have shown marvelous results, together with the study of Nitzan, who showed that you can reach a remission, reaching about 40% or maybe, 52% after 24 weeks. This was associated by biochemical response, improvement in the C-reactive protein as well as calprotectin, and finally, there was a very marvelous improvement in the CES score, endoscopic remission, who happened to occur considerably in about 50% of patients, and they had to report that diet elimination in adults with Crohn's disease really have shown to be very helpful in patients, showing that future will exaggerate again the role of diet, and this is what the future carries concerning diet. We will have diet for patients with strictures. We will have diet for patients with perianal fistula. We assume that we will have specific regimens for every unique disease, for every unique phenotype. Dietary responsiveness should be assessed from the early beginning of our patient, exactly as when you stratify your patient and you put him into a certain category, you also you should also know the response to diet. What happened in surgery also, surgery has always been a remote option to our patients, except in patients who had a localized stricturing disease. Recently, and after the LYRIC study and the marvelous results we have been seeing with patients with terminal ileitis after surgery, things have changed so much. The definition of successful surgery has become not only to reserve the intestine, not only to remove the mesentery, not only to be minimally invasive by a single portal laparoscopy, but most important, we came to early intervention to approach our patients in this window opportunity so as to get the better results. So believe me, surgery will have a role which shouldn't be a remote possibility from now ongoing. In severe ulcerative colitis, in acute severe ulcerative colitis, surgeons have a very important role. They can work on the first day in case of bleeding or perforation, on the second day if they have toxic megacolon or sepsis, and on the third day if patients fail medical treatment. All of us know the role of surgery in perianal disease, and all of us know this very nice systemic review, which shows that 66% of patients will need surgical treatment during their lifetime. For this reason, you can see Paulo from Brazil in the last echo presenting this very nice algorithm, telling us you start in the usual way, using antibiotics, using the biologic, but you have to evaluate at the week 16 and 24. What to evaluate? You will evaluate the status of the fistula as well as rectal healing. And accordingly, you will further upgrade your management. You may try endoscopic techniques such as clipping, which in his personal view doesn't work good, but there are a lot of surgical techniques with touch incisions, including stem cell injection. In this aspect specifically, there is a lot of future coming, not only in the field of stem cell, not only in medications and medicine, but even in other things such as hyperbaric oxygen, for example, modified and advanced supraspinals, and as you can see, a big list of options are coming soon. But the future goal is not only this. It's to collect all what happened in surgery and in omics and in therapeutics and in microbiome and in stem cell. Artificial intelligence will be able to stratify patients and end up in treating patients as groups. And this is really our final target of using all of the advances and future opportunities to our patients. So to conclude, advances are growing in all aspects, not only in therapies and medicine. Artificial intelligence will integrate all of these advances and will be able to carry a future of personalized therapy. Advancement in tool options will also impact the outcome. Dear audiences and chairman, I come to the end of my talk, but really I would like to invite you at the afternoon session of artificial intelligence. How can we apply it in practice? Please come, you can see how can really future affect the advances in management of our patients. Thank you so much.